anastomosis with the left ureter. Decision was then made to intentionally do the same on the right due to the extent of fibrosis and endometrial implant. The patient met her postoperative milestones. She had her stents and Foley maintained for 10 days. She had a JP drain that had been placed during the case by urology that was removed prior to discharge, and she was discharged home on post-op day 3. She was followed up on post-op date for a cystogram that didn't show any extravasation. She had a post-op check with urology. Her Foley was removed, and she had an active trial avoid. And the plan was for continuation of the stents for 3 weeks and a cysto in office prior to removal. She had a post-op check on post-op day 19 with GYN, and her path was removed, showing reviewed, which showed focal adenomyosis, as well as some fallopian tubes with papillary tubal hyperplasia and secretory cell outgrowths or scouts, and her left ureter did show an implant with endometriosis. So I just wanted to briefly just talk about ureteral endometriosis, which is a very rare occurrence with prevalence of 0.1%, but in those with deep infiltrating endometriosis, there's higher rates of 20 to 50%, and that endometriosis could be intrinsic or extrinsic on the ureter, but both types could cause stenosis and obstruction, which was seen in this patient's case. Renal function may be impaired, or they may just have hydroureter and hydronephrosis. CT and MRI imaging can help with surgical planning, but tissue diagnosis is gold standard for diagnosis, and treatment is primarily surgical. Some cases have shown some improvement with medical management, but that typically does not resolve the fibrotic component of the lesion. And surgical goals are to remove the lesion, restore ureteral anatomy, and prevent loss of renal function. I can take any questions.
Thank you, Anusha. Do we have any idea if her hydronephrosis improved after the surgery, or is it too soon and the stents are still in?
I think it's too soon. The stents are still in, but that would be interesting to kind of see what the follow-up scans show.
Can you do me a favor? Can you stop sharing, please?
Oh, sure.
I didn't remember, there were so many details. I must admit I didn't catch every one. What was the patient's opinion regarding hysterectomy at the beginning of the case? That was not planned, correct?
No, it was planned. She did not desire future fertility.
It was a planned hysterectomy.
Yeah, it was a planned hysterectomy. The plan, had been discussed plus or minus the ovaries due to the endometriosis, but she was quite young. So the ultimate decision was to try and leave one ovary.
Right. Well, with only 2 minutes left and no hands up, can you tell me what was the most interesting thing that you learned from this? What question should we be asking?
I think it was interesting, the surgical case itself and what they decided to do with like reimplanting both ureters, and I'm interested to see kind of the long-term outcomes for this patient. But I think it's interesting also to keep in mind like the ureteral endometriosis, even though it is quite rare, if there's a patient maybe with chronic pelvic pain and suspicion for deep infiltrating endometriosis, if they have findings of like hydronephrosis or something like that, considering it could be an endometriotic implant causing it.
With less than 60 seconds left, Dr. Misra has her hand up.
Oh.
Anusha, I just have the question that, do you think when the surgery was started and a survey of the pelvis was done, she would have benefited if she was converted earlier?
Did I answer that question?
Yeah.
One, no. So we converted to open. The case was still incredibly difficult. And the other question, the stent was not helpful. I think this was a failure of, I haven't worked with this team, the urology and colorectal before, because the stent was in place, colorectal cut the ureter. And that's why I usually don't use stents, because I think I had a miscommunication with urology. I was telling them I didn't need stents, and I actually really wanted them to dissect out the ureter at the beginning of the case. They did not agree. They also did not agree that her hydronephrosis was from the ureteral implant, even though I told them there's no other reason for her to have hydronephrosis, it must be from a ureteral implant. So I think the only thing we could have changed is if urology would have dissected out the ureter at the beginning of the case, because the 2 times that I've cut a ureter has been with colorectal, because they're really great surgeons, but they're not used to the idea that that endometriosis pulls the ureter so much more immediately. When doing that pararectal dissection, a lot of times they'll get the ureter. And so I just have to work with my urology team to get them to understand, like, I'm not calling you to just put stents that aren't helpful. And I really, if there's hydronephrosis in a patient with deep infiltrative endometriosis, it most likely is obstructed from the ureteral implant, and the perfect thing to do is to dissect out the ureter. She honestly would have needed ureteral reimplantation bilaterally no matter what, because you could tell from her imaging, but we probably wouldn't have the incidental injury, and the opening did not help. We still cut the ureter. Like, it really didn't help. I actually think a 30-degree scope oftentimes is much more helpful.
All right, I'm so sorry, but we have to switch gears now. We have to go to grand rounds. And I'm going to ask Dr. Sagaram to introduce our grand round speaker.
Hi, can you hear me?
Yes, loud and clear.
Okay, great. So it is my pleasure to introduce our grand round speaker, Dr. Ahmed Khattab. So Dr. Khattab is an associate professor of pediatrics and the clinical director in the Division of Pediatric Endocrinology at Rutgers Robert Wood Johnson Medical School. Dr. Khattab completed his residency and chief residency in pediatrics at St. Peter's University Hospital. He completed his pediatric endocrinology fellowship at Mount Sinai Hospital in New York City. After completing his fellowship, he joined the faculty at Mount Sinai until 2018, after which he joined the faculty at Rutgers Robert Wood Johnson. Dr. Khattab's CV is really quite impressive. He is the director of the Congenital Adrenal Hyperplasia Comprehensive Care Center of Excellence. This comprehensive care center is one of 8 centers in the country for management of congenital adrenal hyperplasia. On a national level, he serves on the subspecialty group of pediatric endocrinology on the American Board of Pediatrics. He is also an active member of the New Jersey Department of Health Newborn Screening Committee, and he is the associate editor for the Frontiers in Endocrinology Journal and associate editor for the 2nd edition of the Genetic Steroid Disorders textbook. Dr. Khattab has also contributed significantly to the research in this field. He has given multiple lectures on the national and international level. He also has over 30 publications and book chapters in reputable peer-reviewed journals and books, primarily in the field of congenital adrenal hyperplasia. So thank you so much, Dr. Khattab, for taking the time to speak with our department today. We are all looking forward to your presentation.
Thank you so much for this presentation and introduction. Just let me know if you can hear me, and I will go ahead.
Yes, loud and clear.
All right, thank you so much. So I will be talking about CH and prenatal management today, and I don't particularly have conflict of interest for today's presentation, but I just put this slide with general potential conflicts of interest. But one disclosure is I have never given grand rounds to OBGYN audience. So I tried my best to make this as relevant as possible. So if there's stuff there that seems too basic for you, it's not basic for me. And if it's a little boring for you, please forgive me. Anyways, I try today to go over the pathophysiology or pathogenesis of 21-hydroxylase deficiency CH, a quick overview, a refresher of the clinical picture, clinical findings of 21-hydroxylase deficiency CH, couple slides on the genetics of CH, or specifically 21-hydroxylase deficiency. And those last 2 parts are going to be a little more relevant to all the OBGYN practitioners and specialists out there, the perinatal management in a woman with CH or a fetus with CH, and general clinical considerations afterwards. Feel free to interrupt if you have any quick questions, and we can address them right away. All right, so I just have a quick fun fact, historic fun fact. I think this is probably the earliest known description of a case of probable CH. It goes back probably 150 years ago, 1865. This Italian anatomist, Dr. Di Crecchio, who had a case or a male cadaver presenting with enlarged adrenal glands, male appearing external genitalia without testicles, and female internal genitalia, basically ovaries and a uterus, etc. So this patient's Giuseppe Marzo, and born initially and assigned to the female gender, brought up as Giuseppina, but from age 4 became Giuseppe and continued to be reared or raised as a male. And as an adult, he joined a household and worked with his father, and actually proposed to marry one of the maids over there, but she ran away when he had to produce his birth certificate because it said Giuseppina. It was never changed. Anyways, Giuseppe lived an exclusive life as a male and even contracted syphilis twice. And he died after a series of vomiting and diarrhea. So that's the thought, that this patient probably had salt wasting CH at that time, just for fun. Anyways, this is the pathogenesis or pathophysiology of 21-hydroxylase deficiency. You can see the hypothalamic pituitary adrenal axis for adrenal steroid synthesis. And with 21-hydroxylase deficiency, enzyme deficiency, there is subsequent disruption of cortisol production by the adrenal cortex. And this leads to interruption of this negative feedback and loss of the inhibition to the hypothalamic CRF and pituitary ACTH. And then this causes excessive stimulation, overstimulation of the adrenal cortex. But given that block, we find that there's shunting, or we see shunting of steroidogenesis to this only intact pathway, the androgen pathway. So the end result here is an adrenal gland that with variable degrees of aldosterone and cortisol deficiencies, but excessive hyperandrogenemia or androgen production. So this was just a reminder of CAH pathogenesis. And how we treat these patients is usually by supraphysiological glucocorticoids. So in other words, we don't just give them maintenance or replacement therapy to replace the missing cortisol. We actually have to give them a little more than that to try to suppress the ACTH-driven hyperandrogenemia. So the amount of glucocorticoids given to these patients is usually probably twice the maintenance, somewhere closer to 15, even 20, sometimes 25 milligrams per meter squared surface area, with the maintenance being just less than 10 milligrams per meter squared surface area. So we classify CAH based on 2 clinical criteria: the presence of virilization of the female external genitalia and the presence of salt wasting. If there is virilization of the female external genitalia, this is automatically classified as classical CAH. This becomes a little harder if we are dealing with a baby boy, because no virilization happens, but I'm glad this is not something most of you guys have to worry about in making the clinical diagnosis of CAH. So if you have if you have virilization and C-virilization or masculinization of the female external genitalia, this is classical. Now, in addition to that, if you find salt wasting, aldosterone deficiency, then you know this is classical salt wasting. In the absence of the salt wasting or the aldosterone deficiency, this is basically simple virilizing classical CH. The non-classical form, or used to be called adult onset or late onset, does not have any female external virilization of external genitalia in the female, nor salt wasting. And the virilization can be anywhere based on that Prouder score, from just mild clitoromegaly to male appearing external genitalia without testicles, of course. The other symptoms or signs that we commonly see are those of hyperandrogenemia, and those can happen in whether it's classical or non-classical CH, like androgenic hair loss, acne, menstrual irregularities, fertility concerns for sure, hirsutism in general. And in the pediatric world, we see patients sometimes showing up with premature adrenarche or puberty of secondary sexual characteristics, rapid somatic growth secondary to all the androgen production, rapid skeletal maturation, basically tall children, shorter adults due to premature closure of their epiphyses and completion of their growth. So what determines this phenotype? How severe or mild would that phenotype? And it's basically how much residual enzyme activity there is. So the degree of 21-hydroxylase deficiency dictates the phenotype, or how severe the phenotype is going to be. And what dictates that degree of 21-hydroxylase enzyme deficiency is really the genotype, or the genetic variant, or the variant of the pathogenic variant. I'm trying to not use the word mutation because the field's going away from using mutation, but I will probably forget and use the word mutation later on. Anyways, so this brings me to talk about the genetics of 21-hydroxylase deficiency CAH, the CYP21A2 or the CYP21A2 gene. And in order to learn about or to understand the genetics of CAH, I had to learn a couple of 101 basic genetic phenomena here. So I'll just share them with you. They probably very basic, but they help me understand how CAH mutations or CAH pathogenic variants happen or occur. So the first one is genetic or gene crossover, and the purpose of gene crossover is diversity. And the second one is tandem duplication. So gene crossover is basically when there's exchange of material during the very early stages of meiosis between those homologous chromosomes. And thus new combinations of genes happen. And this is why all my kids don't look alike, I guess. And the second one would be tandem duplication. And then that's when the DNA sequence is really copied and inserted right in front or adjacent to the original sequence. And that's also another well-established phenomena in genetics of molecular evolution. In most cases, crossing over is beneficial because it increases the genetic variation also. Anyhow, so this is chromosome number 6. That's where the CYP21A2 gene lives, specifically on this locus. And this is a 10 exon gene, and it's about 3.1 kilobases. And it lies within the major histocompatibility complex region, and it's specifically located within proximity of these 3 other genes. And these genes are not involved in adrenal steroid synthesis, but this complex of those 4 genes together is called the RCCX module. And really tandem duplication, which I just mentioned, usually results in a bimodular. So we have 2 modules or 2 of those RCCX modules on chromosome number 6, and they're adjacent to each other. And one of them is, obviously, we're going to be focusing on this one. This is the regular or the functional copy of the CH gene, and this is the what we call the pseudo gene, or the non-functional copy. So this active gene and the inactive gene are very similar. This one is the active gene, and the inactive gene, or the pseudo gene, are extremely similar, probably 98% similar. But about 15 different mutations here render this pseudo gene inactive. We have 4 promoter gene mutations, a mutation on exon 1, an intronic mutation, exon 3, exon 4, this clusteron mutation on exon 6, and so on. So those 15 mutations make this pseudo gene inactive. And we're going to know why we care about this now in a second. So we know there's probably close to 200, even more mutations to date that cause CAH, but 90% of those mutations are really pseudogene derived. And those are the common mutations. If you ever order a genetic test to one of the commercial available facilities like LabCorp or Quest, and you find that there's something called common CAH mutations, Well, they are really common because they happen more frequent than the other mutations, but these are really pseudogene-derived mutations. So it's going to be one of those 15 mutations that they are going to be checking for. This is the PCR product that they're going to be looking for. And the problem is when there's misalignment of these sister chromatids during the mitotic or the meiosis, the early stages of meiosis or mitotic gene repair, then crossover happens. This can result in gene conversion because there's exchange in material between these two genes. So what happens is the sequence from a pseudogene or an inactive gene gets copied to the active gene, making it inactive at this point, and vice versa obviously happens. And this is how those common mutations happen. And this is this process is really called gene conversion. Now you can see those are the mutations. Some of them are mild or associated with a milder phenotype for those promoter, and this is really the non-coding portion of the exon or the gene. And those 4 promoter gene mutations, in addition to a mutation on exon 1 and a very common mutation on exon 7, this VAL281L mutation is probably one of the commonest mutations out there. And in specific populations, namely the Ashkenazi Jewish population, it's estimated to be probably as common as 1 in 3. This could be an exaggeration, but it's estimated to be 1 in 3 Ashkenazi Jewish person is expected to carry this mutation. Obviously, it's very hard to nail it down, but it's just giving you an idea how common this could be. So those mild mutations are associated with a phenotype of non-classical CAH. There's another form here on exon 4. This mutation, the exon 4 mutation, is associated with simple virilizing, and that's here, somewhere here on that spectrum. And then the rest of those, the one intronic splice mutation, and the rest of those mutations, including some frame shift mutations, are associated with severe phenotype or salt wasting phenotype. And in addition to that, there's the deletion, obviously, gene deletion or a large gene deletion here. And I'll just quickly go over this. And again, there's misalignment of those chromosomes or homologous chromosomes during meiosis. And the large gene deletion happens because of unequal crossover here. So think of it this way. This is just really a basic picture of giving you an idea how crossover happens when there's exchange of unequal material here between those two among those two bimodular chromosomes. So you get something like this and another combination like this. If you see this first allele, there's 2 active intact genes here. So if you get to inherit this as a baby, then it doesn't have mutations. But if you get to inherit this, then you become a carrier, at least, of this gene deletion. Anyways, so the genotype and phenotype correlation that I was just going over now is probably very accurate, or close to 90% or even more accurate. And as a rule in general for autosomal recessive conditions, the phenotype is usually determined by the milder mutation. So in other words, if someone carries a mutation that's mild, associated with non-classical, and another mutation that's associated with classical severe CH, their phenotype's going to be that of the mild mutation. And that's a blessing. Now, we know this is an autosomal recessive condition, so the risk of having a child if both partners are carriers is 25%, not about. It is about 25%. So obviously those are the gene conversion and the large scale gene deletion are the 2 primary mechanisms for CYP21A2 pathogenic variants, but other rare mechanisms, of course, occur, like uniparental disomy and so on. This is probably the largest genotype-phenotype cohort or correlation cohort published out there. And I remember working on this. We tried to gather all the information on these patients from our clinical practice and from other providers, and try to figure out their genotypes and correlate that with, did these patients have ambiguous or atypical genitalia? Did these patients have salt wasting? Are they treated for a low sodium, aldosterone, et cetera, et cetera? Did they come back positive on the newborn screen, and so on? And we put together a correlation. And you can see here, if this, for example, I'll use the first one as an example. This is a gene deletion, obviously associated with very severe phenotype, classical salt wasting phenotype. And when there's compound heterozygosity, in other words, one allele carries that VAL281 mild mutation, look at that phenotype. It's always that of non-classical CAH. So the mild mutation takes over. Well, this individual can definitely pass on the severe mutation, but as far as this individual is concerned, the phenotype is very predictable here. So why is all this important, and why am I going over all this, especially for people who are taking care of pregnant women? And it's really for genetic counseling. Your CYP21A2 genotype at preconception is important to define the individual risk for the individual you're taking care of. So if you have an offspring risk, if you have a carrier couple, like a couple, and these days we have all those preconception, genetic panels that people will show up to your office with, and some of those panels have CAH gene as one of those genes they check for. So you want to be able to determine the offspring risk for an affected or a carrier couple, or for couples who have a CAH affected child. That the proband exists. They come up to your office like, okay, we have a child with CAH. Is our next pregnancy going to have CAH? What is our risk? And then, of course, the major morbidity most people are going to be talking about is the genital virilization, or the masculization in the female external genitalia. And this is why, and they start asking, is there an intervention to prevent genital virilization? And can pre-implantation genetics play a role here? And of course, this is one of the few, or a monogenic disorder, that can benefit from all that prenatal counseling and intervention, because the phenotype and the genotype are very well correlated, and it's monogenic. So it becomes a little straightforward than we have for other conditions. And then there's prenatal dexamethasone treatment, or treatment of the pregnancy with dexamethasone to try to prevent virilization of the external genitalia in the classical CAH affected fetus. And of course, this is an experimental treatment, and the Pediatric Endocrine Society and the Endocrine Society deem this as experimental, not clinical practice use. It is a huge area of controversy in the field of CAH. I am not necessarily advocating for or against. I'm just sharing information here. It's been around for 30, 40, 50 years probably, and it continues to be that area of controversy with a lot of back and forth. So make sure that you understand this is 100% experimental. The option, obviously, or the regular mainstream, or the common option that was usually utilized, is genital corrective surgery. Prior to the 80s, they used to remove the clitoris. After that, clitoral resection, or sorry, not resection, clitoral recession and reduction, basically tucking in that clitoris, was performed. And that was extremely painful, especially at times of puberty or after puberty, when clitoral erections occur. This was extremely painful, and it's really something that was not very welcomed by most of the patients. But in the past 20 years or so, the major procedure that most urologists are following now is the nerve-sparing clitoroplasty. And they aim to restore the external genitalia to the typical appearance, the male appearance, and of course, to restore any urinary, reproductive, or sexual function that has been lost. This is a procedure that really needs expertise. It's not performed in expert hands, except in probably 5 centers in the country so far. So it continues to be a challenge also to find an expert inside your state that you can actually go to. So this is another challenge, having these surgeries done. Of course, surgeries come with anesthesia risk, fibrosis, scarring, strictures, urinary tract infection, leakage. Of course, the impaired sensitivity that's been reported in the past with decreased sexual satisfaction and frequency, et cetera, et cetera. We don't know the best timing, but it's probably early, sometime after the first year or at the end of the first year, to prevent the psychological impact and stigma associated with atypical external genitalia in these females. And there is a concern that's raised that genital corrective surgery for virilized 46XXCH females basically may pose a challenge, because some of those manifest gender dysphoria later in life. And now after genital corrective surgery, this may not have been the choice retrospectively. And that's why we've had all the back and forth and legislations recommending, hey, how about we delay the sex assignment surgery in such conditions until the age of consent. And that dysphoria is a little different from the gender behavior traits or the masculine gender behavior traits. And we know that patients or females, little girls with CAH tend to like to play with cars or toys, and they have male related behavioral traits. But gender dysphoria is a little different. Gender dysphoria has been reported to be about 5% in females raised 46XXCH raised as females. Probably, or in my personal practice, I did not feel it was that much, but that's a number that's been published out there, and that virilization or gender dysphoria doesn't really go hand in hand with virilization, so it's sometimes hard to predict. So it's not like the more the virilization, the more likely there's going to be gender dysphoria. So it gets a little difficult, and that's why there's that thought or ask to, hey, how about we postpone those surgeries until patients can actually decide for themselves. There's obviously a long discussion we can go for here, pros and cons, but that's really the fact out there. So we know that dexamethasone readily crosses the placenta and can suppress the adrenal gland of the fetus to decrease the androgen production. And you would basically, if using this, you would be administering that to the pregnant woman who you think carries a female fetus with classical CAH to try to prevent that genital virilization. And you would continue that to term until the delivery, of course, if this was confirmed to be classical CAH. And you would confirm that by your karyotyping or the NIPS or genotyping and obtaining a fetal sample from amniocentesis or CVS and genotyping the CYP21A2 gene. It does largely spare most of these females the consequences of genital virilization and surgery, and it decreases the exposure or the high level of androgens they're exposed to in their brain during differentiation. The question is it really effective? And the answer is probably is effective. Those are 2 mutation identical siblings. The first child was born with atypical or external genitalia, and the second child who had exact same mutations was prenatal treatment. Now, this is probably the best case scenario here, but if you look at those outcomes that were published by Maria New, and this is about 30 years of data or 30 something years of data in Cornell University, and they looked at all the patients that had DEX versus no DEX treatment. And if you look at this classical female treated with DEX, the average Prater score was somewhere between 1 and 2, closer to 2 or 1.7. And the average Prater score in those who did not receive DEX, prenatal DEX, and they were only 11 women or 11 girls, was between 3 and 4 and closer to 4. And just to let you know, probably Prater scores less than 2 usually rarely require genital corrective surgeries. So it's probably effective. But I'm just going to go over a scenario just to try to illustrate this a little more. If you have a carrier father and a carrier mother, they're known to have they have a child with CAH, and this child was born with genital virilization. So you know this child has, or those parents are carriers, and they have a risk for their next pregnancy for a child to have CAH. And the couple would like to discuss with you options to discuss this prenatal virilization, this fetal virilization, if it were to be a female. And the question is, what are the chances this couple is carrying a CAH, or this mother is carrying now a CAH-affected fetus? And given that we know this is autosomal recessive, it's 25%. So you can say, well, there's a 25% or 1 in 4 chance your pregnancy, the baby you're carrying now, is going to have CAH. But the question is, if this is a girl or a boy, then the chances of having a female fetus that does have CAH is half. So it's 1 in 8. And they're asking now about the early prenatal DEX therapy. They're 5 weeks pregnant, and the thought would be, okay, well, you have the option of early, but it's going to be blind prenatal therapy, something like 20 mcg mics per kg pre-pregnancy weight. And this has to be administered before the timing of external genitalia differentiation, somewhere before the 8th or 9th week of gestation, in order to prevent that process from happening. And you would basically continue the DEX, the prenatal DEX, until you're able to determine that CAH status and or the karyotype. So that if this was a 46XX fetus that does have those mutations, the 1 in 8 chance, then yes, you'd continue that prenatal DEX treatment until delivery. But the chance, the other chance is 7 out of 8 of the times, this is either going to be a boy, so you don't need to really do anything because boys don't get virilized, or it's going to be a girl that's either a carrier or did not carry any of those CYP21A2 pathogenic variants. And at that time, you'd say, okay, sorry, we unnecessarily exposed you and your fetus for this DEX for a period of time until you're able to get your CVS. That's probably going to be something close to 13, 14 weeks. That's probably going to be a good 7, 8 weeks or something like that, at least. Most of the time, it's much more than that, given the timing to get results back and so on. Now, we know this is effective in reducing the external genital virilization, possibly eliminating the need for surgery, decreasing all the androgen level exposure for that baby. But the risks are obviously a ton out there. There's risk for maternal side effects, exposure to DEX that's been associated, or there's reports that this is associated with working memory deficits and with negative outcomes or cognitive outcomes. And we don't have long-term data about this safety or the safety profile in these pregnancies exposed to DEX. And you have to do an invasive procedure like basically CVS or an amniocentesis, and you're probably going to expose 7 out of 8 pregnancies unnecessarily to DEX. And your ethical question really comes, it's like, is it ethical to expose really 8 pregnancies to DEX, the maternal and fetal exposure here, to prevent virilization in one of them? And there's no really right or wrong answer here. Some people would be like, yes, I want to do this. I want to expose my fetus, myself. I do not want to have any risk of genital virilization as pregnancy. And some of them would be like, I do not want any exposure, whether my fetus has CH or not. But a lot of people would be like, well, if I only knew that this pregnancy was really a female and is affected by CH, that's when I would do the targeted treatment here. And non-invasive prenatal diagnosis was the way to go. It avoids all those invasive procedures. It's very early, and it can avoid the unnecessary exposure to 7 out of 8 of those pregnancies. And we did have this demonstrated in 14 families, and we started treatment or we got results as early as 5 or 6 weeks of gestation. And the idea is really obtaining the cell-free DNA. So we had a trio, basically a mother, a father that are known to be carriers, and a proband, child who's affected. And we looked at the cell-free DNA, something like a teaspoon of maternal plasma, just a regular blood draw, as early as 6 weeks of gestation. And you determine the fetal inheritance by looking at informative SNPs or polymorphisms from the trio and look at their representation in the maternal plasma. And thus you can determine if this fetus has inherited or has not inherited those mutations. And we confirmed those on newborns, but unfortunately, this didn't go very far. COVID came after that, et cetera, et cetera, et cetera. But it's still something that someone needs to pick up and proceed with. With proper implementation of something like non-invasive, you can probably not have to expose the fetuses that are not affected and target treatment if that was something the parents have looked at. I'm trying to finish on time, and I think I will. I have a couple of slides at the very end about some clinical considerations in practice for CH. So there's a switch in gears here. If you have any questions about the first part of the talk, feel free to interrupt now, or we can do everything at the very end. Okay, so just a couple of clinical considerations, and the first one is if your patient has non-classical CAH, can you assume that, okay, well, you don't have risk for classical CAH in your current pregnancy or your upcoming pregnancy? And the answer is no, because most of those patients who have non-classical CAH, or a lot of them, have another allele. They're compound heterozygotes. So they basically carry this mild mutation, and that's what you see on their phenotype. But hidden there is their carriers or compound heterozygotes. They have a severe mutation. They can pass on to their baby. And if their partner also carries a severe mutation, then this baby has a chance of developing CH or classical CH. So the assumption that, okay, this mother has non-classical CH, her fetus is not at risk, is not correct. So without genotyping, you can't assume or make that comment. If the mother obviously is homozygous for those 2 mild mutations, that you know that the child is going to inherit at least one of those, and then whatever he or she inherits from dad doesn't really matter on the phenotype. Theoretically, given the incidences or prevalences of these mutations, a patient with non-classical CH has a 1 in 350 risk of having a child with classical CH. If you have 350, if you're taking care of 350 women with non-classical CH, maybe one of them will have a child with classical CH. Okay, so prenatally, non-classical CH looks like PCOS, as far as I'm concerned, at least. And we had mentioned how common that VAL281L mutation or the exon 7 mutation is in certain populations. And the thing is that a lot of patients with, or all the patients with PCOS are probably diagnosed, because you need those symptoms to make that diagnosis, but not all the patients with non-classical CH are diagnosed. So there's a chance that non-classical CH, or we know non-classical CH is way more prevalent and common than we think. Some people are asymptomatic. They live all their life, didn't even know they had non-classical CH. Some children present with early puberty signs. So that is a spectrum that a lot of people lie on the very mild end of the spectrum. The elevated androgens and progesterone, it can disrupt that hypothalamic pituitary ovarian axis. They can cause oligoovulation, fertility concerns, irregular periods, a lot of times, and I'm not saying treat all your patients with non-classical CH with low-dose glucocorticoids, but I'm just saying that low-dose glucocorticoids sometimes is sufficient to improve symptoms, facilitate pregnancy, improve acne. This is a picture before and after 0.25 milligram of Dex at night for 3 months. So if you're taking care of a patient with presumed PCOS, for accuracy, you may want to order a 17-hydroxyprogesterone level. You know that half of these women with non-classical CH are probably going to conceive without the need for glucocorticoids, and even more of those are actually undiagnosed out there. If your question, or the question we want to ask ourselves, like, are pregnancies less in CH? So basically in the CH community, are they less fertile? Do they have less children? And it's probably a mixture of a couple of things. Obviously, we know the disrupted hypothalamic pituitary ovarian axis. There's social and behavioral considerations too. There's the interest in motherhood, or less likely to be in a relationship. There's all the anatomical and surgical outcomes, favorable or unfavorable, with some difficulties in vaginal intercourse have been reported. And we've seen patients who have problems with vaginal intercourse secondary to their surgery. Possibly some of them need dilation and so on, which is a very painful procedure. Is there possibly more prevalence of homosexuality that's been reported out there? I did not feel so in my own practice. But if you have a mother with CAH, especially if this is classical CAH, they need to be treated with hydrocortisone, and she's pregnant. She needs to be treated. Her treatment needs to be hydrocortisone mainly. And you can also consider prednisone or prednisolone, which are inactivated by the placental 11-beta HSD hydroxysteroid dehydrogenase enzyme, but not dexamethasone. And dexamethasone will cross the placenta. And obviously that's why it's used for prenatal treatment. So unless you really want to initiate fetal treatment, dexamethasone should be avoided in these pregnancies. You would usually use the regular dose in the first and second trimesters. You may require glucocorticoids a little higher last trimester, the third trimester. And remember, if these women are vomiting continuously, hyperemesis, you probably want to give them their glucocorticoids some other way. These people are at risk for adrenal insufficiency. They have been on long-term glucocorticoids. They could have adrenal insufficiency and they could go in a crisis. So if they're vomiting, there needs to be another route of administration. They need stress dosing for any flu, intercurrent illness. They need to be educated, as well as their partner, on the administration in case of emergencies of those Solicortef or hydrocortisone intramuscular injections. They should all wear a medical alert bracelet. Good luck with that. A lot of times it's hard to convince people, but they should be wearing a medical alert bracelet. God forbid they go through an accident. They need stress dosing. They need an alert bracelet to tell EMS these people need hydrocortisone. Pregnant women are increased risk of gestational diabetes, and that's probably because of the steroids they're on. There's more likelihood of infection, higher rates of cesarean section, maybe anatomical, etc., or gestational diabetes, etc. And at labor, obviously, there needs to be stress dosing. This is probably one of the most important things, especially if they're undergoing C-section and there's surgery involved. They usually take something like 100 milligrams at the onset of labor. And a lot of times we like that to be intramuscular, so the release becomes a little sustained, and followed by 200 milligrams over the next 24 hours. And they continue that depending on their recovery after the delivery. So I think I'm actually doing great with time, and I have one last slide. And that's just a new treatment in CAH. I'm not sure how many of you actively treat patients with CAH or classical CAH, to be more specific. But like I said, historically, or since CAH was discovered, the treatment has always been glucocorticoids, and not just glucocorticoid replacement. It's also glucocorticoid suppressive therapy to try to suppress that androgen pathway from being overstimulated. And new treatments have been released recently on the market, actually last December, and we're starting to prescribe those. And the hope is that this new treatment, which is a CRF, or the corticotropin releasing factor 1 receptor antagonist, this block here reduces the ACTH production by the pituitary gland, and you disrupt the pathway more proximal, and you would still require glucocorticoids, but in this case, you don't need the suppressive therapy. You'll just be giving glucocorticoids in a physiological manner, which makes a lot of difference for us and for everyone, really. And then lowering that cumulative burden of glucocorticoids, even if it's by a small amount, for years of life, is going to hopefully have a lot of improvement in their quality of life, their BMI, their risk for diabetes, insulin resistance, their bone health, etc. So if you are treating patients with classical CAH, this could be another discussion. Obviously, it's not used in pregnancy, and we don't know the safety. The safety profile seems to be very satisfactory. But obviously, it's such a new medication to say, well, go ahead, take it when you're pregnant. But anyways, that's just something to keep in the back of your mind. And this was my last slide. And thank you all for your time. But before I finish, I'll just go over two tiny things real quick. On the right side is my mentor and friend and partner who left us last year, unfortunately, Professor Marion Yu, who I worked with for something like 15 years. And I would always like to give her a small prayer and a thank you every time I talk about CAH. And if, well, that was probably something you heard today earlier, but we are one of the 8 centers in the country for CAH care. We're not a surgical center, but we are a non-surgical center. We do have a lot of patients with CAH. We do encourage a lot of or we would like to have a lot of collaboration. And if you want to collaborate with us for clinical care or research, feel free to reach out. This is something we always look forward to doing. And thank you so much for your time.
Thank you, Dr. Khattab. Thank you so much. Are there any questions? Well, I was interested, Dr. Khattab, what was the patient's perspective on the blind treatment, on the taking this medicine from whatever 6 weeks to 17 weeks, that a chance of the baby needing is only 1 in 7. When you asked your question, who would recommend this, and you said some people would say yes, I said yes right away. But how did the patients respond to that? The pregnant women.
So this was a very, very delicate subject. I feel it's how they initially heard about it. So there's 2 ends of the spectrum out there, whether it's in the press. This has been on New York Times. There's been a lot of negative and positive talk about this. So if you happen to be someone who read or looked at the negatives and those made more sense for you, a lot of people were very resistant to it. It's like, I don't care whether I have a child or I don't, then I'm not doing this. A lot of patients until today are like, no, this is a benefit that outweighs the risk of genital virilization, going through surgery, going through this and this and this. And if I have to expose unnecessarily for some time during the pregnancy, I still would like to do it. So it was really a hit or miss here. And that's why the prenatal, if you had more information, targeted treatment would probably be something that levels the ground, if I may say. So it's really hard to say. If you ask me personally, I feel it is something I kind of think, because I've seen a lot of morbidity going on with CH, but again, not everyone is the same. They think the same. It's such a tough question. That's why I always highlight that this is experimental, and it's not something to be just done. We treated a lot of patients, and a lot of them are now graduating from college. They did great. I don't know if this is, and there's been literature out there to suggest that all the negative outcomes were actually related to the CAH, not to the prenatal treatment. So it's really hard to tell.
I'm shocked by that, especially if they've already had a baby that was affected. But anyway, Dr. Patrick has her hand up.
Good morning. Thank you so much for this talk. I'm one of the MFMs, and so definitely was interested in everything you had to say. I was extremely intrigued by the data you showed us about the NIPT. And I'm curious because I think you said you were doing that as early as about 6 weeks gestation. And, you know, traditionally when we use non-invasive prenatal testing for things like aneuploidy, you know, the lab recommends waiting until 9 weeks due to no calls because of low fetal fraction. There's some data that came out at SMFM last year that we can probably do it as early as 7 to 8 weeks, but 6 weeks was really soon. So I'm very excited by that, but also curious if you had to have people come back for retesting, or if you had some no-call results doing it that early.
Okay, so for full disclosure, those were only 14 patients, and it was one of them who was tested at 6 weeks, right? So basically 5 weeks and 6 days. So the sample size is tiny, 14 patients, but all of those were validated or were confirmed after the baby was born. We did not have any misses here. But again, it's 14 patients. Some of them were, or a lot of them were actually after the date of that you could have done a karyo an amniotype or an amniocentesis or a CVS. It was just a pilot proof of principle study. So it stopped there, but it's really you're right. There could be a lot of contamination or maternal plasma contamination from a prior pregnancy. There's a lot of pitfalls that can be, but our our data was only 14 patients. I don't know if that answers your question.
Yeah, well, I hope you all pick that back up, because, you know, again, the earlier we can do targeted therapy, I think would be ideal. So, you know, even if you were doing testing at a more traditional time, you could probably have some result by about 10 weeks, 9-10 weeks gestation, which is still much earlier, as you pointed out, than we can get from CVS. We could probably, maybe if we did it as early as we could and the lab turned around really quickly, maybe have you an answer by 12 to 13 weeks. So yeah, that's very exciting, and I hope that that takes off.
I see that Elena has her hand up.
Good morning. Haley, I just wanted to add to what you said. That was something Maria New was doing at Mount Sinai with Dennis Lowe. Dennis was the founder of Ariosa. If you remember, we did their prospective recruitment to validate their NIPT. And I'm pretty sure that patient, that 6-weeker, was actually ours from Robert Wood. So they did have some no calls, but you should be able to pretty easily at least see if there's Y chromosome material. You may not be able to get a molecular read, but you can definitely at least predict the fetal sex. So at least you can reduce that, you know, a little bit more targeted. You may not have a molecular diagnosis, but you can definitely at least establish the fetal sex.
Correct. Yes, it was Dennis Lowe. You're right, 100%.
And when Maria, passed away, and, I think it probably, and Ariosa obviously got bought and Dennis went in a different direction. So I think that's probably where that collaboration stopped.
Correct. I don't know if it was Sequenom or I forget the names, but you're right. Your story is 100% right.
Yeah, it was Arios. I remember because we had,
maybe we talked at that time.
Yeah. Yeah. And so, I mean, I've been a genetic counselor for 26 years. And before the whole controversy, it was pretty, I used to see a lot of patients who, because where I was working at the time, but we'd see patients all the time whose fetus was at 25% risk, and people didn't hesitate to initiate treatment until the fetal sex was known and the molecular diagnosis was secured. It wasn't controversial. It was just something you did. And then when the media came out with the data that this is potentially causing developmental disabilities and adding to adverse outcomes, it was a very rapid shift and became really controversial. But prior to that, this was pretty mainstream.
Correct. And it was really mainstream that I, as a pediatric endocrinologist, and Maria treated pregnant women. We didn't even have to, have them have their OBGYN treat them. But at this point, everyone's really careful that, okay, well, you better be treated by a specialist. So yeah, you just really summarized everything I wanted to say. It's a really tough one. It depends if you're someone who's treating children with learning disabilities, you may be someone who's more biased on the other end of the spectrum. But if you're a urologist who's not looking for surgeries, you would probably be biased to the other end of the spectrum.
Exactly.
It's really,
and now with cell-free DNA screening, we're in a position today where we are diagnosing these disorders of sexual differentiation. Patients are having their cell-free DNA screening nice and early in pregnancy. They think they know the fetal sex, and then they present for their level 2 ultrasound, and we tell them it's something to the contrary. So we are diagnosing, disorders of XY that look female, XX that look male, and expanded carrier screening. A lot of these panels today are including the 21 hydroxylase gene. So, we may be we're finding them later, unfortunately, at this point, past the point where treatment would even be of benefit. So Dr. Khattab and I will be doing a very interesting talk. I look forward to it. Thank you so much for agreeing to do it with me at the Philadelphia Prenatal Genetics Conference. We're going to take all of our interesting cases where we diagnose disorders of sexual differentiation, and he's going to teach the audience about the medical management moving forward as we diagnose these kids. So thank you again, Dr. Khattab, for agreeing to work with me on that project as well.
Thank you so much. Thanks for inviting me. I appreciate it.
With just 3 minutes left, I see Dr. Rosen has his hand up.
Hi, Dr. Khattab. Thank you for the talk. I didn't get a sense of what side you're on with the prenatal treatment with dexamethasone for fetuses with no CAH. Did you give us an opinion on that?
I did a good job not giving an opinion, I guess. I am on, or I historically was on the side of doing prenatal treatment. But I think those are my just 2 cents. I always like to inform my patient of all the pros and cons. But if you're asking me about my personal thought, I would go with the prenatal treatment side, given the fact that I've had to see a lot of morbidities in my practice.
All right, thank you.
All right, well, Dr. Khattab, thanks again for this excellent talk.
Thank you so much for having me. You guys have a great one.
Thank you. So with that, we're going to conclude Grand Rounds. I hope everyone has a safe and successful day.